say it is the part of the cerebral peduncle that's called the crus cerebri that they pass through, right? But I choose to use cerebral peduncle, and I'll tell you why later. Then now we'll go to the pons now. You have ever, look guys, you have all seen a sagittal section of the brain stem, of the brain, right?
Sir, earlier, I don't know if was one here. You said the dorsal part is also called tegmentum, but isn't it tectum?
No, tegmentum. I know what the tectum is. Forget about that. Don't talk about that. Tectum is midbrain, yeah. But the midbrain also have a tegmentum.
Yeah.
Right? So in other words, the ascending sensory system don't pass through the tectum. Tectum is a different thing, right? Pass through the tegmentum. So every part of the brain stem have a tegmentum, and that's where the ascending sensory system passes. We'll talk about the tectum and some other one. We're going to talk about that today. Yeah, and then now once we leave the ventral part of the midbrain, the next bus stop, remember midbrain, pons, medulla. The ventral part of the pons is the big belly part. You see that part? Good. We call it the basilar pons, or they say the ventral pons. That is where the descending motor systems pass through. So after they come out of the crus cerebri, they then pass through the what? Basilar pons, right? That's the most ventral part of the pons. And then once they come out of the basilar pons now, they're going to be in the ventral part of the medulla, which is the what? Pyramids. Which is the pyramids. Okay? So the pyramids is where we have the what? Descending motor systems. I want you to think about it that way. Yeah. Okay? And then once it comes out of the medulla now, it is now in the what? The spinal cord. Now which part of the spinal cord? The ventral part. So it's in the ventral motor horns, right? The ventral horns where the motor neurons are. That's where they're going to synapse. So I want you to think about it like that. So remember now, those systems that are ascending to go up to the brain, they're going to travel through the tegmentum. Those systems that are traveling down from the cortex to get into the spinal cord, they travel on a different road, the ventral road. The ventral part of the midbrain, we call it the cerebral peduncle. You can call it cruciferous, no big thing. Ventral part of pons is the basilar pons. Ventral part of medulla is the pyramids. All right. Okay, so today now we're going to talk about the midbrain. And you should know by now that the midbrain, when we look on the gross feature of the midbrain, you'll remember that the dorsal part of the midbrain have 4 little bumps that we call the corpora quadrigeminum. The 2 top ones are the superior colliculi, 2 bottom ones are the inferior. Now you can do a cross section of the midbrain at either of those levels. Right? So you're going to see a picture of the midbrain at the level of the superior colliculus and one at the level of the inferior. We're going to start off with the level of the superior colliculus. And you must swap off. When I did anatomy, I had to write an essay on the midbrain, right? Give a large label diagram of the cross section of the midbrain at the level of the superior colliculi and write short notes on the different nuclei that are present there. Right? So you have to know it. So, what is it here now? Drawing is always non-symmetrical. looks like in cross section. So we start off with this. This is what the midbrain looks like in cross section. Next week when we come, I have one to cut for you to see for yourself. But this is what I want you to put in your head now. A line. Okay, let me just point out the different nuclei first. So these are the two superior colliculi. This is the aqueduct of Sylvius, and this bigger circle around it is the periaqueduct of gray matter. Then on either side, this sausage-shaped structure on either side is what they call the lemniscal system. Lemniscal, L-E-M-N-I-S-C-A-L, lemniscal system. The word lemniscus is Latin for ribbon, ribbon-shaped system. And of course, this lemniscus is divided into a medial lemniscus, lateral lemniscus, spinal lemniscus, and trigeminal lemniscus. So medial lemniscus, trigeminal lemniscus, and spinal lemniscus. Okay? Good. And of course, this is the what? Red nucleus. That's the red nucleus. And this blue thing here is the substantia nigra. And then this thing that is divided into three parts is the crus cerebri. Okay? This thing that I've divided into three parts is the crus cerebri. I'm going to go through it now. The substantia nigra. Okay, now, if you draw a horizontal line, look, if you draw a horizontal line through the aqueduct, horizontal line through the aqueduct, I should have gone through the middle of it, but it's okay. That line is now going to divide the midbrain into this part above. That's called the tectum. So that's the tectum. And then everywhere else below is the cerebral peduncle. The rest is the cerebral peduncle. Cerebral peduncle. So the midbrain is divided into a dorsal part, that's called the tectum, and a ventral part, that's called the cerebral peduncle. Now, the part of the cerebral peduncle, guys, look. The dorsal part of the cerebral peduncle, this part that's close to the tectum, this part of the cerebral peduncle, look, this part of the cerebral peduncle is the tegmentum. Tegmentum. So the upper part of the cerebral peduncle is the tegmentum. Okay? And then now, look, this part down here is the crus cerebri. Some people call it the basis pedunculi. Basis pedunculi. I want you to also notice that the tegmentum is separated from the crus cerebri by the substantia nigra. Okay? By the substantia nigra. Also observe, guys, that in the tegmentum of the midbrain, you have some structures in there. In the tegmentum of the midbrain. The one that stands out is this area of yellow that I've put here. That is the reticular formation of the midbrain. Is in the tegmentum of the midbrain. And notice that this is more towards the center of the tegmentum. The reticular formation of the midbrain is in the center of the tegmentum. Notice on the lateral side of the tegmentum, we have the ribbon-shaped thing that we call the lemniscal system. It's on the lateral side of the tegmentum. Of the tegmentum, okay. Yes, on the lateral side of the tegmentum. As a matter of fact, you guys have done spinal cord, and I don't know if you remember that the ascending sensory systems that travel in the spinal cord. We have the dorsal column ones that are on the dorsal aspect. We have spinal thalamic that's on the lateral side, and the spinal thalamic maintain that lateral position all the way up the medulla, all the way up pons, all the way up the midbrain. Okay? Of course, when these systems reach the rostral part of the medulla, the dorsal column system, which is going to cross the midline and becomes the medial lemniscus. Okay? So it changes name in the medulla to medial lemniscus. The rostral part. So the rostral is the top part. So if you remember in anatomy, caudal means down the bottom, the tail part, and rostral is up the top, right? So when it reaches the last part of the medulla before it becomes the pons, it going to cross the midline and change its name to medial lemniscus. Okay? And the cross.
This is not like the this is not the arch. This is before the arch.
For the what?
The arch. This after the arch.
The what? Arch? Yeah, so that crossing is called the internal arcuate fibers. You know?
So this is after the change its name.
Yes. So once it has crossed from left to right, the name now is no longer dorsal column, it's now medial lemniscus. Right? Alright. Now look here. What I want you to, well, we'll talk about that, but let me not get ahead of myself. Yes, yes. No, the spinal lemniscus is spinal temperature, spinal thalamic tract. So spinal thalamic tract at this level, they don't call it that anymore. They call it spinal lemniscus, alright? And of course, trigeminal is a combination of spinal lemniscus and medial lemniscus, but this time from the where? From the head. Okay? So the trigeminal thalamic is proprioceptive information, 2-point touch, pressure, pain, temperature, and so on from the where? Head. Okay? Alright. Of course, also in the tegmentum we have the red nuclei. Yes? And then of course, below that now we have substantia nigra and we have the crus cerebri, right? So what I want to do now is we want to start from the top in detail and come down. I want to mention something else. Look, the periaqueductal gray matter. Periaqueductal gray matter, guys, is considered to be part of the reticular formation of the midbrain. So the periaqueductal gray is considered to be part of the reticular formation of the midbrain. Part of the reticular formation of the midbrain. Now, it would be remiss, guys, it would be remiss of me to not mention. So this is the aqueduct of Sylvius, and this part of the periaqueductal grade would be the what? The dorsal part. So this part is dorsal to the aqueduct of Sylvius. This part is what? Ventral. So look here now. Ventral to the aqueduct of Sylvius in the periaqueductal grade is the third nerve nucleus. So anybody asks you where the third nerve nucleus is located, you're going to tell them that the third nerve nucleus is in the midbrain at the level of the superior colliculus in the periaqueductal gray matter, just ventral to the aqueduct of Sylvius. So it's a whole heap of words you're going to be using there. Oh, this chalk thing I'm working on the top. What I want you to observe is that I'm putting in 4 nuclei, 2 on either side of the midline, right? These are the nuclei of the third nerve. Notice. So let me encircle the nucleus of the third nerve, see there? So that's the oculomotor nucleus. Anybody asks you where you find oculomotor nucleus, you're going to say midbrain, sir, at the level of the superior colliculus, and it's ventral to the aqueduct of Sylvius and inferior aqueduct of Gray matter. Why do you think I have two different colors? Because these, what color is this? Orange. These orange ones are the motor nuclei of the third nerve. So those orange ones are the motor nuclei of the third nerve. What do you think the yellow ones are? Third nerve does no sensory nucleus, guys. Parasympathetic nuclei. You know what they call? Edinger-Westphal nucleus. That's the Edinger-Westphal nucleus. Huh? So the orange ones are the motor nuclei, and the yellow ones are the Edinger-Westphal nucleus. Come, let's start from the beginning now. Let's start from the beginning, guys. I have to also include something dorsal to the superior colliculus. Dorsal to the superior colliculus, we have a nucleus. That's called the what? Tectal nucleus. Pretectal nucleus. So the pretectal nucleus is just dorsal to the superior colliculi. Pretectal nuclei. Alright. So let's start with the pretectal nucleus now then. So pretectal nuclei are concerned with what? What's the importance of those nuclei? They are concerned with the pupillary light reflex. Pupillary light reflex. These neurons located there project to the Edinger-Westphal nucleus. They're dorsal to the superior colliculus, yeah. So there's no pretectal in the inferior. No, don't say that. You could say it, but you're wrong. So the pretectal nuclei, as you can see on the diagram, are located just dorsal to the superior colliculi, and they are concerned with the pupillary light reflex. This is a topic by itself that I will discuss with you, but I will just say that these pretectal nuclei, write this down, receive input from the optic tract. So the pretectal nuclei, so we know something about optic tract. Most of the optic tract fibers go into the LGB of the thalamus, but a few fibers deviate from LGB and end in the pretectal nuclei. And then the pretectal nuclei now relay to the Edinger-Westphal nucleus. You get that? Okay. Now, this will serve you well. Somebody in the clinics may ask you which disease destroys pretectal nuclei. And I've told you before that it's tertiary syphilis. Tertiary syphilis mash up a whole heap of things. One of them that it mash up is the pretectal nuclei. And as a result of that, it abolishes the pupillary light reflex. You can still accommodate, but the pupillary light reflex is abolished. And so the patient is now diagnosed with having Argyll-Roberts syndrome. Argyll, A-R-G-Y-L. Your name, Roberts, you're Roberts or Robertson?
Robertson.
Yes, so Argyll-Robertson syndrome.
Wait, but
Huh? Robertson.
So sir, you use everything in your life?
Yes. That's like, they must be in life, you know. And you're going to find out how it helps the memory a lot. Argyll-Robertson syndrome. I know what I always used to remember that is tertiary syphilis. Dr. Prof. Hanson always say if you can find a celebrity, a famous person who has a particular disease, you can help you to remember the disease, right? So I always remember Al Capone from the United States. He died in prison of tertiary syphilis. Al Capone. biggest gangsters in American history. They couldn't catch him on anything else, so they caught him on tax evasion. Put him in prison and he died there of syphilis. Okay, let's move on now, guys. So don't forget, Argyle-Robertson syndrome. Look it up on YouTube. Okay? Alright, let's move on now. We want to talk about the superior colliculi. That is the main thing in the tectum. So again, I have to remind you that the tectum is the dorsal part of the midbrain, and it contains the what? Corpora quadrigemina. For this lecture, we're talking about the superior colliculi only. So what's the function of the superior colliculus, guys? Visual what? Vision. The superior colliculus have nothing to do with vision. Visual reflexes. In fact, I don't even like to use visual. I like to say eye reflexes. But you're correct. Visual reflexes. Okay? Visual reflexes. That has to do with what? Eye movement. Eye movement. I must also remind you that when we did endocrine, I told you about which organ lies superior to the colliculi. The pineal. And we've talked about a lesion in the pineal compressing the superior colliculi and can disrupt upward gaze. Remember? Okay. So the thing to write down is the center for upward gaze lies in the midbrain at the level of the superior colliculus. Write that down. Center for upward gaze. So this the center that allows you to do that. Gaze upwards. You have a lesion there, you can't do that.
So it lies in the...
Was that like a
Sunset gaze. Sunset gaze.
So it lies in the superior colliculi.
It lies in the midbrain at the level of the superior colliculus. Okay, so let's talk a little bit now about the connections of the superior colliculi. And every time you approach anatomy, you must approach it like that. Connections, right? When I gave you your exam when you were a student in a different faculty, or same faculty but different thing, you got a question, I give you a question like that. Right? Give a large labeled diagram of this midbrain at the level of the superior colliculus and give short notes on the numerous nuclei present there. Now, let's talk about the connection of the superior colliculus. The superior colliculus gets lots of inputs and it gives lots of outputs. We want to talk about the main inputs now. What are the main inputs? Give me the major input to the superior colliculus. The biggest one, what? Good, spinal tectal is, no, don't write that there though. Spinal tectal is an input, but it's not the biggest. But that's the next one we're going to come to. Anybody know the biggest input? The biggest input is corticotectal. Write that down. So the most, well, I shouldn't say most important, but the biggest input to the superior colliculi is the corticotectal. And of course, corticotectal tell you coming from the cortex, right? What it doesn't tell you is which part of the cortex is coming from. So this input is coming from the frontal eye field and the primary visual cortex. I don't know if you remember when we did the superior lateral surface, I showed you the frontal eye field. And what did I say the function of frontal eye field was? Eye movement. Right? Eye movement. Okay? So the main input to the superior colliculus is the cortical. I'm going to say it again. Main input to the superior colliculi, corticotectal. And this corticotectal is coming from two cortical areas, the frontal eye field and the primary visual cortex. For those who want to know, the frontal eye field is Brodmann's area 8. And this is how we normally do it in anatomy, to remind you. See the 8, we turn it sideways to make it look like a pair of glasses. Right? So you know it's eye. So the frontal eye field is Brodmann's area 8, and you know that the primary visual is Brodmann's 17. So 8 and 17 project. That's the main projection to the superior colliculus. Next question. How does this projection get to the superior colliculus? Which road does it walk on to get there? let me help you. First, it travels, the corticotectal first travels through the internal capsule, and then the last part of the road is it jumps onto which pathway? Superior brachium. Superior brachium to get to the superior colliculus. Okay? Superior brachium. So all these things that we're talking about, you must, when you get the chance, you want to look up what is the superior brachium, so I'm talking about, right? Good. Another important, oh, by the way, this corticotectal serves two purposes. One, eye movement. Some books say conjugate eye movement. But another one, the one coming from the primary visual, is for accommodation. So that pathway coming from frontal eye field, eye movement. That part coming from primary visual cortex, accommodation. That's what these pathways serve, function. And then as you said now, another big pathway too is spinotectal. That's what he said, right? Spinotectal. So I give you one pathway, corticotectal, another one, spinotectal. Something like that. Oh, sorry. Good. So anybody know what this spinotectal pathway is for? Remember, no, you know, every pathway we mention, remember what function of the superior colliculus is eye movement, right? So what do you think now? Spinotectal. What is that pathway for? Is what? Yeah, but still, you have to be more specific. You know, if it's spinotectal, what do you think that pathway is for? You said? He said sensory. But again, sensory. Remember, vision is sensory, too, you know. And hearing is sensory. So you still don't tell me nothing. Yeah, give me, let me hear what I'm saying.
Like, let's say you walk in and you book it to, you immediately go and look down. That's an example.
Okay, that's not a bad example. That's not a bad example. But I don't like it. It's not a, I would give you like maybe 50 out of 100. And when I show it to Mr. Gardner, he said, oh, no, that's too generous. Give him 30. Right? No, let me just tell you to get rid of all this garbage. So it is this now. So the spinotectal pathway is a reflex pathway. Write that down. The spinotectal pathway is a reflex pathway. For turning of the eyes and the head. So the spinotectal pathway is a reflex pathway for the reflex turning of the eyes and head towards the source of a cutaneous stimulus.
No, that's
Cutaneous, but that's not cutaneous. You get me? That's not cutaneous. But you got the turning your eyes and the head are part of it, right? But that's not cutaneous. So cutaneous is sensory, right? And cutaneous would suggest what? What kind of sensation? Yes, from the skin, and that would include what? Information coming from mycinus corpuscles, Pacinium corpuscles, and all these things, right? So let me give you an example of what we're talking about now. So I'm giving this thing, and everybody seems very interested, and suddenly a fly pitches on your hand, and you do that. You just reflect the turn. Or one of your colleagues deciding to play a prank, and you take out a thread and just run it on your skin, and you just look right away like that. Okay? That's the reflex pathway, right? So look here now, guys. So this spinotectal is the afferent limb, right? So the spinotectal is the afferent limb of this reflex pathway. You have that? So the spinotectal would be the afferent limb of the pathway. And what do you think would be the efferent limb now? So which pathway would be the efferent limb to get your head and your eyes turned to the source? No, remember now we're talking about superior colliculus. So you just tell me that is spinotectal. So what's the? It will be tectospinal. But what will tectospinal before? Turning the head. But what about the eyes? It will be, oh, there's no cortex in this thing. There's no tectocortical either. So what do you think? All right, look here. If you go and turn your eyes, which cranial nerves would be responsible for that? Which cranial nerve? Cranial nerve what? 3, 4, and 6. Let me get the formula. LR6, SO4, 3. So where are those cranial nerves located? In the brainstem. What we call the brainstem? The bulb. So what do you call the pathway? Tectobulbar. Tectobulbar. So the efferent limb of that pathway would be tectospinal, going to the cervical part of spinal cord for the reflex turning of the head, and tectobulbar now for the reflex turning of the eyes. You get it? But since we're just talking about afferents, I want you to stick with the two afferents we have gone with so far. We said corticotectal and spinotectal. Those are the two afferents, right? But I just went ahead and finished the pathway and give you efferents as well. But the two afferents were mentioned, spinotectal and corticotectal. Do you know any more afferents to the superior colliculus, guys? What? Alright, so we're here talking, right? I'm talking to you. And you suddenly hear a gunshot. And everybody look over there. Good. So tell me about that pathway now. What would be the input? What would be sending the auditory information to the superior colliculus? Inferior colliculus. Okay? So another input to the superior colliculus is inferior colliculus. Alright? And what is that pathway for? What's that pathway for? Reflex turning of the head and the eyes towards the source of a loud sound. Yes, so a third input to the superior colliculus would be the inferior colliculus. And that pathway is for the reflex turning of the eyes and the head towards the sound of an unsuspected loud sound, right? You can make up a pathway. You can say collicular if you want. Or tectotectal if you want, right? It don't matter.
So it's just fibers going from inferior to
Colliculus to superior colliculus. So look here, guys. So excuse me. So that pathway from the inferior colliculus to the superior is a afferent, right? So that would be the afferent limb of this pathway. What would be the efferent limb? It would be the same thing like before. Tectospinal, tectobulbar. Same thing. Same thing. Agree? Tectobulbar. Remember now, the tectobulbar is a different thing for the eyes, you know. And tectospinal is for the neck. You get me? Do you know any other inputs to the superior colliculus? Well, in neuroanatomy, whatever goes on this side, it has to go on the other side. So this colliculus project over to this one, and this one project to this one. So you can say superior colliculus also gets input from the contralateral superior colliculus. Okay? You got that feeling?
Are there any more?
Yes, one last one. One last one, guys. One last one.
I have a question. When you talked about the spinal pathway, right?
Yes.
And you said that
You're not gonna win.
afferent. And then you said the two afferents is the tectospinal and tectobulbar.
Yes.
I mean, efferent and afferent of what pathway?
Yeah, so remember now we said that this is a reflex pathway for turning of eyes and head towards. It's a reflex pathway. So remember, reflex pathway has an input and an output, right? Good. And both of them are reflex pathways. That one where you have to hear the loud sound is a reflex pathway as well. So there's an input and an output. And the input in this case is the afferent, output is the efferent. And both of them have the same output. Tectospinal, tectobulbar, right? Alright. And then now, finally now guys, don't forget that although we said the optic tract ends mainly in the LGB, we said some fibers of the optic tract went to go to pretectal nucleus, and a few fibers also go to the superior colliculus. Okay? A few fibers also go to the superior colliculus. And then now, so that's how much afferents I've given you, about 5. And then now, you know the efferents, we just mentioned them. 2 efferents. What are they? Tectospinal and tectobulbar. Very good. So those are the connections of the what? superior colliculus. Alright, so we're moving on now. We're moving on, guys. Everybody? Alright, let me pause. The more, these guys don't realize, you know, the more I pause, is the more time we waste, and the less we cover. Okay, so let me pause. When you guys are ready, tell me. No, I can't talk when anybody's talking. So when you want to talk, I'll get quiet. Alright, so we're talking about now the aqueduct of Sylvius. So this aqueduct of Sylvius can be called either aqueduct of Sylvius or what? This is the aqueduct of Sylvius. It can also be called what? The cerebral aqueduct or the midbrain aqueduct. Okay? So it's the cerebral aqueduct, the midbrain aqueduct, or just the aqueduct of Sylvius. And what does it connect? Yes, connects the third to the fourth ventricle. What is it lined by? Epididymal cells. Good. Now what we're saying is the green matter that surrounds it, guys. Everybody? The green matter that surrounds it is the periaqueductal green matter. And this green matter is considered to be part of the reticular formation of the what? Midbrain. Now, let me just remind you that the reticular formation of the brain stem itself is for arousal and wakefulness. So write that down. So the reticular formation of the brain stem is for arousal and wakefulness. I always say arousal, not just sexual arousal, but other arousal too, right? Just to be aware and be aroused to everything. And wakefulness. Some people say if you want to stimulate the reticular formation, when you wake up in the morning, go wash your face. They say washing your face stimulates the reticular formation and helps to wake you up. Okay?
You're supposed to be washing your face also.
Yes, yes.
So question is, so sunlight will also stimulate the reticular formation.
I wouldn't say that. I wouldn't necessarily say what's.
Darkness stimulates.
Yes, sunlight stimulates the pineal gland, and that in turn stimulates the what we call the circadian rhythm. Right, so that's a part of it. But let me go back to this now. So the reticular formation of the brain stem, guys, is a continuum. They're not separate from each other. So the reticular formation of the midbrain connects to the reticular formation of the pons and to the medulla. It's a continuum. A lot of neurons connecting to each other. Everybody have that? Yes. The reticular formation of the brain stem is a continuum. It's not separated from each other. So the entire brainstem reticular formation is connected to each other, yes. And so we say the function of that reticular formation is arousal and wakefulness. But I want to make a very important point. However, the reticular formation in the midbrain is for the maintenance of consciousness. That's very important. Not only is it for arousal and wakefulness, but the reticular formation in the midbrain is for maintenance of consciousness. That means an infarct in the vessel that supplies the tegmentum of the midbrain will result in a deep, deep coma. Okay? Yeah, so our destruction of the reticular formation of the midbrain will result in a deep coma from which the patient will never come out of. Okay. Yeah. Now look here. Look here, guys. Everybody. The periaqueductal gray matter contains some neurons that produce natural opiates and enkephalins. Everybody get that? Yes? Yes, so the periaqueductal gray matter has some neurons that produce natural opiates and enkephalins. And these help to modulate the descending pain pathway. Modulate the pain pathway. So these natural opiates and enkephalins help to modulate the pain pathway. And when I used to live on Taylor Hall, I had a friend who used to, she was a medical student, 17-year-old girl. She'd get up every morning, 5 o'clock, and jog to Halfway Tree and jog back to Taylor. And She was, every morning she jogged, she was the nicest girl ever. Anytime she never jogged, most grumpy, miserable person ever. Right? So one theory is that exercise stimulates production of the enkephalins, right? So anytime she get hooked on those enkephalins, and so when she didn't jog, she got grumpy. And withdrawal symptoms. Alright, let me sit down now. Alright. Now we come to the periaqueductal grade, the ventral part of it where the third nerve nucleus resides. And just to remind you of the little mnemonic, LR6SO43. Just to remind those who don't know it, LR6SO43. These are 3 cranial nerves. 6 is abducens, 4 is the trochlear nerve, 3 is the oculomotor nerve. These 3 cranial nerves have their cell bodies in the brain stem, and they are responsible for extraocular movement. Note that of the 3, only two muscles are not supplied by the third nerve. Only the lateral rectus, which is supplied by 6, superior oblique by 4, only those 2 muscles that are not supplied by the third nerve. Third nerve supplies the other 5 muscles, okay? And so most of the extraocular muscles are supplied by the third nerve, all right? That means a third nerve palsy going to result in diplopia, which is double vision, right? Double vision. And of course, double vision will occur because it means therefore that the third nerve will now be what? Opposed. So in other words, these other muscles, so remember now, look, the lateral rectus pull the eyeball that way, and the medial rectus, which is supplied by the third nerve, pull it this way. If the third nerve is paralyzed, that means there's nothing to oppose lateral rectus. So you also see somebody with an eyeball looking at you and an eyeball looking over there. You call that lateral strabismus. Strabismus. But don't worry about it. We talk about that. Anyway, come guys. So the point is the third nerve supplies most of the what? Extraocular muscles. The third nerve also has, in addition to those motor fibers, the third nerve have what? Parasympathetic fibers. Those are the Edinger-Westphal fibers. So if this is the third nerve, look, this is the third nerve here, right? The fibers that my fingers are on are the Edinger-Westphal fibers. In other words, those fibers are the more superficial fibers. So the Edinger-Westphal fibers are running superficial to the motor fibers. What does that mean to you? It means that when the nerve is compressed, it is the parasympathetic fibers that go first. Now, what are some of the things that can cause compression of the third nerve? First of all, raised intracranial pressure. Okay, everybody? Raised intracranial pressure can cause compression of the third nerve. And what are the things that can cause raised intracranial pressure? Huh? A space-occupying lesion, like a tumor, right? Hemorrhage, those things. A man drop off a tree, ligament on a stone, him start bleeding the cranium, and the pressure starts to build up. Okay? And so, our man meeting a motor vehicle accident, never have him seatbelt on, and him head hit the windscreen. Some blood vessel rupture and starts bleeding. Right?
Sir, is it impossible to have a tumor of the choroid plexus?
No man, it's common. These things common. That's why we say a space-occupying lesion. So you can't have any tumor in the brain that take up space will cause the pressure inside to increase. You get that? So now guys, when them bring that man to you, all you have in your little practice is a bed, 2 chairs, and some little medicine, right? How can you test for this thing? To see if this man have a space-occupying lesion and getting compression of the nerve. How you know? Now man, you just take out the flashlight and shine on the man's eye and see if you get the constriction of the pupil. And if it does not constrict, then you know that something is wrong. You get that? So you just write a little referral letter to the UU hospital for the people in the neurology clinic or neurosurgery to see, right? See, everybody get that? So a good test to tell you a whole heap of information is the light reflector we talked about. Huh?
These parasympathetic fibers, what exactly do they do?
Good. I'll just tell you. So, okay. So look here, guys. So you see when the third nerve, everybody? When the third nerve, see one of the third nerve here, coming out of the brainstem, and it leaves the brainstem like that, on the medial side of the crust. So when you look on the specimen, we want to see if we can see a third nerve coming out on the medial side of the crust. Once it comes out here, this is the third nerve here. On the surface of it, so these are the motor fibers, but also running with the nerve are the Edinger-Westphal fibers too. Yeah, where do you think this nerve is going? What's the destination of this nerve? Yeah, but which place is it going? Into the orbit, right? How does it get there? Which foramen it pass through? Superior orbital fissure, right? And once it gets into the orbit now, it's going to divide into a superior branch and an inferior branch, right? And these branches are going to supply the muscle, extraocular muscles. However, the Edinger-Westphal fibers are going to come off and synapse into the ciliary ganglion. And then the postganglionic fibers will leave ciliary ganglion and go to a muscle in the iris known as the sphincter pupillae muscle. And those muscles constrict and cause the pupil to constrict. You get that?
So damage to it would cause the pupil to dilate.
Well, a damage to that will cause the pupil to dilate. Why? Because the dilated pupillae, which normally antagonizes the third nerve, is supplied by the sympathetic system. And the sympathetic is normal, it won't have any opposition now, and it will cause the pupil to dilate.
What was the postganglionic you said?
Ciliary ganglion. Yeah, the postganglionic fibers now will go to the sphincter pupillae muscle. Everybody get that?
Sphincter pupillae is a circular muscle of the iris.
Yes. Everybody get that? Alright, so we're moving on now. Ready? Alright, so let's move on now. So we already talked about the lemniscal system, right? And don't forget that the medial lemniscus is really the dorsal column system. Let's talk a little bit about this dorsal column system now. So if I were to ask you, just say, ask somebody to stand up, and I say, which part of this guy's body is this dorsal column system coming from? What do you say? Just general. Is it coming from the head, or where? Where is it coming from? He said, it's coming from the entire body, sir, except the head. Okay? So the dorsal column system is coming from the body, but not the head. You get that? Good. The next thing we're going to ask now is what information, what modalities are being transmitted by this dorsal column system. So don't go too fast. Vibration sense, 2-point touch, proprioception, and what else? Pressure. Good. Pressure, right? Very good. Yes? Yes. Which is the same thing as discriminatory touch. Good. So the next question I'm going to ask now is which receptors now are transmitted this information. So let's start with each of them. So vibration and pressure. Which receptor is transmitting that information? Pacinian corpuscles. So next question, where do you find these corpuscles? Give me some examples where you find them.
Fingertips.
Eh? Fingertips? Okay. And where else? Well, the fingertips. Yeah, so you can say palm or fingertips mainly, right? And where else? Sole of the feet? Not much, no. Where else? The breast? Also. Nipples? I don't think so. That don't make any sense. You agree? That don't make sense.
What is going on?
Look here, guys. Can I say something? Does the nipple experience any pressure in real life? Does it experience any vibration? All right, so let's move on then. If the answer to that question is no, then we move on. Yes?
Isn't it vibration that causes
Vibration.
I just did it.
How would that vibration go? Would you connect it to a stroboscope or some sort of vibrating thing? We're getting really kinky here now. The answer is no, guys. There's no Pacinian corpuscles in the nipple. Look, that is not to say that we don't have lots of sensory receptors there, but not vibration and pressure receptors. But give me some more examples where you find Pacinian. Well, yes, not bad. And why would you have in the pancreas?
Oh, what you talking about?
Because of its topographical relation to the stomach. Good. But give me another example. The vagina.
What I was supposed to
You know,
say?
like the wall of the vagina, Pacinian corpuscles in there. What about the urinary bladder? Oh, yeah. Yeah. Anything else? What about the joints? Yeah. Oh, of course. Good. So what about proprioception now? So which part of the body first? The joint. The joint. Right? And then now, which receptors in these joints? Joint capsules, Golgi tendon organs, muscle spindle. Very good. Right. Now, let me ask you another question now. What information you think this proprioception will bring when it comes to the brain? I remember all of this is now going to go where? Post-central gyrus, and then from there to the parietal lobe. So what information this proprioception will bring to the brain now? Information about what? Proprioception we're talking about. Information about what? Joint sense position. Yeah. Good. Joint sense position. So the position of your body parts in space.
So we call it the knowledge of space. What do you call it?
Stereognosis.
Stereognosis. Alright, so we're moving on now. And remember now, guys. So what about proprioception from the head? Where's that coming from? Is it forehead? Forehead, which part of the head transmit proprioception? Because we said trigeminal lemniscus have proprioceptive information there.
Oh yeah, because
So which part of the head?
trigeminal.
Which part of the head? Show me. Just put one finger on. Yeah, here? Where? She's showing you there, look. Where's that? In a ear? No, sir, it's garbage.
Oh, externally.
Coming from a joint. No joint it must come from? Which joint? TM joint. TM joint. Oh, Lord of mercy. Is there no balm in Gilead?
I don't.
You guys don't read the Bible?
I don't know.
You don't read the Bible, sir?
Not very often.
Anyway, come. Let's move on. We're moving on. And then, of course, you know that the spinothalamic tract transmits mainly what? And what? And temperature. Is that exclusively pain and temperature?
You have pressure.
No, it have no pressure. No. It have light touch. Light touch. Right? So pain and temperature and some light touch. Spinothalamic tract. So stay with us, okay? So look here, guys. Everybody, hello. The spinothalamic tract, which is the receptor for pain. What is it called? Nociceptors. Nociceptors. So the pain receptors are nociceptors. Now, when you do the pain pathway, guys, I remember in my anatomy exam, one of my questions I got was trace the pain pathway from the tip of the index finger to the cerebral cortex. And that's not bad. My examiner told me I got full marks. And at the time, full marks was 17 out of 25. 17 out of 25. Prof. T gave me 17 out of 25. For a good while, I had my essay, piece of everybody can read it.
What's 17 out of 20?
Yeah, that's good. In medicine, 17 is good. There's a man in Mobe, when you do junior surgery, a man called Dr. Frey. He's going to tell you if you can get a good 51 in surgery, you're a good student. 51%. Oh, 51%, yeah. You're a good student, a good solid surgery student. Anyway, come, let's move on now. Let's move on. So we're moving on now. Look, guys, look. We're moving on. Everybody, we're moving on now to the red nuclei. Red nuclei. And I want you to look and see, look here, I want you to see how the third nerve leaves the brainstem in relation to the red nucleus. It's leaving on the what? Medial side of the red nucleus, and it come out in the interpeduncular fossa on the medial side of the crus cerebri. See that? Don't forget that. Okay? Okay. Just to tell you, incidentally, I don't know why I'm wasting all this time telling you all these peripheral things, but it's important to tell you. Look here. This blood vessel is coming up here is the basilar artery, right? This is the basilar artery coming up like that. And as it comes up, it gives off several branches. This would be the anterior inferior cerebellar. And then you have labyrinthine artery. Then you have some little pontine branches. Then you have the superior cerebellar. And then you have finally the posterior cerebral artery, right? When the third nerve comes out of the brainstem, it's going to run in between the superior cerebellar and the posterior cerebral. Now, this part of the artery that gives off the branches is known as the basilar tip. Okay? So the basilar tip is, you could say, is the end of the basilar artery where these branches come off. Now, I got in my neuroanatomy multiple choice a question that says, an aneurysm in the basilar tip could compress which of the following cranial nerves? And the answer is the third nerve.
So it's between superior.
So it emerges between the superior cerebellar and the posterior cerebral artery. And of course, you know that aneurysms are very common. Very, very common things. Give me one of the commonest aneurysms you've heard about. Very aneurysm. Very good. Alright, so the red nuclei now, guys. Red nuclei are considered to be part of the motor system. Right? So the red nuclei are considered to be part of the motor system. In the freshly cut specimen, the nuclei are actually red. And they're red because of the high content of cytochrome oxidase in those cells. High content of cytochrome oxidase in these cells. In man, the red nuclei are not as developed as in other primates. So make a note, in man, it is not as well developed as in other primates. But you should still know the anatomy of it and should also know the connections of it. So the connections, what are the two main connections, two main inputs of the red nucleus? Where most of this, remember now guys, if I say input, then whatever you tell me, the last word must be rubral. So where most of the input to the red nucleus comes from? Cortex. So cortical rubral. And give me another input. Miss Robertson, can you give me an input? Okay, that's fine. 100 marks. So another input, guys, to the red nucleus comes from the inferior olive. So what do we call that pathway? Olivorubral. Olivorubral. Now, the output, in neuroanatomy, they say connections tend to be reciprocal. So if you know one connection, you basically know two, right? If you only knew the olivorubral, you also know rubral olivary. So one of the outputs from the red nucleus is back to the olivary nucleus. So we call that rubral olivary. But also, the red nucleus projected spinal cord. So rubrospinal is another very important output. And look here, that diagram of big cross section of the spinal cord, right up there in the lateral part of the funiculus, right beside the lateral corticospinal tract. is the rubrospinal tract. I don't know if you remember that. You will obviously don't remember that, so we'll talk about that. But anyway, so guys, so two main input, corticorubral, olivorubral. Two output, rubro-olivary, rubrospinal. But there are some other little small connections that I have to mention. So write these down now. So when you do cerebellum, there's a nucleus in the cerebellum that's called the dentate nucleus. That nucleus projects to the red nucleus, so we call it dentatorubral. So write that, dentatorubral. All of the function of all of these things going to become evident when we do them. Just write the thing down and try to commit it to memory. When you do spinocerebellum, there's a nucleus in the spinocerebellum. Everybody? There's a nucleus in the spinocerebellum that's called the interposed nucleus. And let me just try to make it a little more understandable to you. You see that nucleus we call the dentate nucleus? It comes from a part of the cerebellum that has to do with synergy of movement, fine skilled movement. Okay? So the dentatorubral has to do with skilled movement, precision movement. In anatomy, we just leave all of them fancy words and just talk about synergy of movement. Okay? So dentatorubral deals with synergy of movement. When you do spinocerebellum, the spinocerebellum is primarily responsible for posture, tone, and gait. And that nucleus in the spinocerebellum that we call the interposed nucleus projects to the red nucleus as well. So we call it the interpositor rubral. Okay? Interpositor rubral. So those are some additional input to the red nucleus.
What's the function of the interpositor?
For posture, tone, and gait. And then now, so we said the red nucleus projects back to the inferior olive. We said it projects back to spinal cord. But the red nucleus, guys, also projects to the thalamus. So it says rubrothalamic. Rubrothalamic. So those things, just keep them in the top pocket and you're going to add on them as we go along. We're building a house, brick by brick, right? But don't let me come next time and you don't even know the first brick. Alright, so we're moving on now. That's the red nucleus. Okay? Let's talk about the substantia nigra now. So the first thing to tell you is that the substantia nigra is part of a group of nuclei in the brain called what? Basal ganglia. So the substantia nigra is part of a group of neurons in the brain that's called what? Basal ganglia. Well, when I was a student, you know what I was the worst at? Taking notes. Because if I can't get every single word, I do like what he do and just sit down and don't take no notes at all. No, let me tell you, if I go home and read my notes and 3 words missing, I can't read it. I get miserable. So in the end, I just sit down and just listen because I can't. So when I see these people writing, I take off my hat to them. Seriously. Hey, I had a friend when I did anatomy from camp, you know. The girl had 4 different colors. And she just underline, do this, do that, and she get every single thing. Me have 1 pen, 1 color, and me can't get none. Anyway. Yeah man, but think about it. He said don't depend on me for everything, you know.
Input.
No, remember now, if we end with rubral, it must be input. Remember? Rubral is whatever, rubral. I mean, it's going into the red nucleus as input. Output now would start with the red nucleus, rubra something another. Right. Anyway, so that's the what? Substantia nigra. Look on it, guys. This substantia nigra has 2 parts. It has 2 parts. Look, this part is the more ventral part. This part is the more dorsal part, right? The more dorsal part is called the pars compacta. The more ventral part is the pars what? Reticulata. Pars compacta. Pars reticulata. Okay. So we said that it's part of the basal ganglia and it has 2 parts. Now the pars compacta, guys, which is the more dorsal of the two parts, contains dopaminergic neurons.
Okay, which one is that? The compactor?
Yes, compacta contains dopaminergic neurons. That means it contains neurons that produce what? Dopamine. Those neurons are also pigmented. Pigmented. And that's why the thing is what? Black. That's why the substantia nigra is the black substance. Now, interestingly, infants, when they're born, substantia nigra white. And with age, it gets black. And then when you reach a certain age, it starts to get white again.
Parkinson's syndrome.
Well, not necessarily Parkinson's syndrome, but when you get old and dementia starts to set in, you get white again. And then when you have Parkinson's disease results in a destructive lesion, a destruction of those dopaminergic neurons. So they're dead. There's no more melanin in those cells because the cells don't exist anymore. All right? So when the pathologist wants to do an autopsy now on a patient to see if the patient had Parkinson's, first thing goes straight to the brainstem, take a section of the midbrain and look, and if it's white, that proves that he had Parkinson's. If it's black, the patient never had Parkinson's. Right?
So the blackness will reflect on
No. If you can't, huh? Yeah, man. Yeah. You don't cut it. You have to take out the brain and cut it. Yeah. Interesting. Anyway, what's a part of medicine I hate? I love anatomy, but I hate pathology. What's up? No, they don't go hand in hand. Let me tell you. Anatomy.
That's in physiology.
Let me tell you. Listen to me. Anatomy. We have some specimens here that, as far as I'm concerned, are not people. I just see some stiffening comes like that. I don't know what they are, right? But I know I can see the median nerve and all those things. But when I go to pathology now and they pull the sheet, I see somebody just like that. So that's a person. And I can't stand up and see them rip out the tongue and all those things. No, so can't see that. You don't like that. Huh? I go outside to stand up until the whole thing done. And guess what? One day I went outside to stand up, and guess who comes stand up beside me? One of the pathologists. And she says she has children, and what she can't take is when they're doing autopsy on the kids. She come outside and stand up beside me. She can't manage that. Now, me have an ex-pathology friend in Cornwall region. I go look for him. When him done, him say, "Come go have lunch now." I say, "Come." He open this door. When I look, a cadaver on the ground over there, so step over next one, step over next one. About 15 people, they don't have enough space, so they have people all over the ground.
You have lunch in there.
No, we just step over them and go through the back door and go in there and fancy care and go have lunch and come back. You don't mind these things. You understand?
I have to have that mindset.
Anyway. Yes, so we're saying that it is this part that has the dopaminergic neurons, guys. This part, the compactor. The reticulata has no dopaminergic neurons. Now, a destructive lesion, as I said before, in the substantia nigra, going to result in Parkinson's disease. Or some books say Parkinson-like syndrome. Okay? So a destructive lesion in the substantia nigra will result in Parkinson's disease. Now, Parkinson's disease, just like the diseases of the basal ganglia, so a disease of the basal ganglia in general, of the different basal ganglia nuclei, result in something they call dyskinesia. So make a note that a destruction in the basal, in any of the basal ganglia nuclei, result in something they call dyskinesia. And those of us who have done physics know what kinetics is, movement, right? And dyskinesia is disruption in movement, okay? So the movement, depending on which basal nucleus it is, the movement can be exaggerated or the movement can be reduced. So you can have what they call hypokinesia, where a little bit of movement, stiffness. Or you can have hyperkinesia, where the limb just move uncontrollably and you can't stop it. You have to actually hold it for it to stop. Okay? some people have some little movement like this. Strange movement, right? So you have all of these different extremes of movement disorders with respect to basal ganglia. But with respect to the substantia nigra, you tend to get dyskinesia. So let us talk a little bit now about some of the features of Parkinson's disease. By the way, anybody here know any famous person who died of Parkinson's or who has Parkinson's?
The guy from Back to the Future.
So Muhammad Ali and that guy from Back to the Future was Michael J. Fox.
Yeah.
No, he's alive still. But I don't know if you have ever looked at Muhammad Ali and compare him to Michael J. Fox. What's the difference you notice with Michael J. Fox?
His features are more.
No, Michael J. Fox can't stand still. He's giving an interview and he's doing this.
Strong corridor.
Yeah, stop. No, he's tired of mouth, but he can't do nothing about it. He's just moving. Whereas with Muhammad Ali now,
He was just like this.
he has this resting tremor like that. You saw
When he
the
carried
pictures
the
of the Olympics when he
torch?
carried the torch. He's standing up like this, and when they give him the torch, he take it and the tremor is gone, and he light the thing. There's no tremor, and he hand it back, and then now when he stand up, the tremor come back again. So write a note that for a lesion of the substantia nigra, you get something called resting tremor, a resting tremor. And it's important that you're able to differentiate a basal ganglia lesion from a cerebellar lesion. Cerebellar lesion give you intention tremor. Intention is when you got to do something, the tremor start. So that's an intention tremor, that's a cerebellar lesion. But a basal ganglia lesion, you have a resting tremor. When you're not doing anything, the tremor is there, okay? So Muhammad Ali has a resting tremor. Huh? Yes, cerebellar lesion give you an intention tremor. Okay. So that's one feature of substantia nigra lesion, a resting tremor. Another feature, guys, is this. They tend to have a stooped posture. Right? So stooped posture, that's another feature. When you go to the medicine, these medicine people ask you. And the thing is this, when we walk, we reflexly, walk and swing the limbs, and we don't even notice it. But for these people, because of the stiffness, when they walk is like this, you have a shuffling gait. The foot is shuffling on, you can actually hear the foot shuffling on the ground. So third, shuffling gait. Another thing you'll also notice with Muhammad Ali, they say even before he died, he still had a high sense of humor, Or even when he giving joke and laughing, there's no expression on his face. So there's no expression, right? So they say they have a masked face. So write that down, masked face.
Sir, question. Damage to pituitary gland.
Huh?
Damages to pituitary gland.
To the what?
Pituitary.
Pituitary. I thought you were talking about something. Yeah.
Do you think the oxen have fine tremors as well?
Yes, but that's for a different reason. Because the pituitary gland produces a whole heap of substances, dopamine, melatonin, all these things. All right, this is for me. You drop out. All right, so that's that. And by the way, guys, these Parkinson's patients also tend to have hypertonia. Hypertonia, okay? So the interesting thing is this, guys. These patients with Parkinson's disease have a difficulty in initiating movement. So the man sits down like that, somebody knocks on the door and he says, I'm coming. And you're watching him and he's still sitting down. And you're like, didn't he say he was coming? And then you go have breakfast and come back and he probably reach here. Right? So they have a difficulty. They have a difficulty in doing what? Initiating the movement. But guess what? Once they have initiated the movement now, they can't stop. Yeah, so write a note that the Parkinson's patients have a difficulty in initiating the movement and a difficulty in terminating the movement. So once they reach the destination, they still can't stop. So they often just bounce up in the door or something, right? Very, very, very difficult disease. Good. And then now, we need to talk about the connections now of the substantia nigra. So the connections. So the main connection, the main input to the substantia nigra is from another basal ganglia known as the striatum. Some people call it neostriatum. So one of the main input to the substantia nigra is the neostriatum. What happened? Oh, tell her hi for me. Neostriatum. So what would you call that input therefore from the neostriatum to the substantia nigra? Striatum nigral. I can say striatum nigral if you want, but I just call it striatum nigral, right? Good, striatum nigral. And then now, in anatomy, connections are reciprocal. So the output from the substantia nigra goes back to the striatum. So what's that called? Nigrostriate. Nigrostriate, good. So striatum nigral, afferent, efferent, nigrostriate. And then the last thing to tell you about this now is that the pars reticulata, write this down, it is considered to be a displaced portion of the globus pallidus internal, which is another basal ganglia nucleus, right? So the pars reticulata is considered to be a displaced portion of the globus pallidus internal.
That's a part of the
Lentiform nucleus, right? Part of the globus pallidus internal. And then finally, pallidus, just put GPI.
Internal.
Yes. So look here now. Finally now, guys, we talk about the crus cerebri, also known as the what? Basis pedunculate. Notice that the crus cerebri is the most ventral part of the cerebral peduncle, right? You agree? What is the most dorsal part of the peduncle? The tegmentum. Alright. So look at the crus cerebri now. They divide it into three parts. You have a medial 1/5. Why they call this medial 1/5? Why this is the medial part? Because it's close to the midline. And therefore this will be the lateral 1/5. And what is this? Intermediate 3/5. Intermediate 3/5. Now, remember what we said? Guys, remember what we said? The ventral part of the brainstem is where you have the what? Descending motor systems, okay? Descending motor system. So it's the descending systems that go into the spinal cord pass through here. Yeah, so this one now, let's look on this one. What passes through the medial 1/5? Elizabeth? Frontopontine. Frontopontine fibers pass through the medial 1/5. And the question is this, where are these frontopontine fibers coming from? Sir, as the name suggests, they're coming from the frontal lobe. And where are they going? To the pons, to synapse on the pontine nuclei. Good. And then now, look, the lateral 1/5, what passed through these, Liz? So you said the other pontine fibers. Everybody?
Save the life.
What part? Everybody? Everybody? What's passing through the lateral 1/5 are the other pontine fibers. Temporopontine, occipitopontine, and paritopontine. Where are they going? To the pons. So, let me put it another way. These pontine fibers, the frontopontine ones, and the other pontine, when they go to the pons, where are they going to go after that? They're going to cross the midline and go to the cerebellum. Which part of the cerebellum? The part that deals with synergy of movement. So what you can say is that these pontine fibers are for synergy of movement. Write that down. These pontine fibers are for synergy of movement. So look here, everybody, look here. You say, I'm standing here, right? And something said to me, you know what? Take up one of those chalk and draw a diagram for these people. From I conceive of the idea, the corticopontine fibers start right away. And what do these corticopontine want to do? They want to go to the pons, and from there go over to the cerebellum and tell the cerebellum that Solomon want to pick up the chalk. What the cerebellum do now? Cerebellum give rise to the dentato-rubro-thalamic pathway. For what? Synergy of movement. Right? We're going to talk about all of that when the time comes. And then now, the intermediate 3/5 is for the corticospinal and what? Corticobulbar. Okay? Good. So we have done everything. Only two things are left over this diagram. And yesterday when I finished the class and I reached home, I said to myself, shit, I forgot to put it in.
Or that was the one.
Which fibers?
Okay guys, so I've left out two things from this diagram. Look,
She was asking.
What did you say? The lateral fifth? What fibers were?
lateral 1/5,
Yes, sir.
parietopontine,
So one.
occipitopontine, and temporopontine. In other words, all the other pontine fibers.
He says that all of these pontine fibers, which includes medial one and lateral one,
Yeah.
go to the cerebellum.
No, first of all, they go to the pons, the synapse on the pontine nuclei. Then we cross the midline to the contralateral cerebellum for synergy of movement. But we're going to go through all of that. When we do cerebellum, we're going to go through that. So look here now, guys. Two things are left out of this diagram I'm going to have to include. Look, there's a nucleus on either side of the periaqueductal gray, and that's the mesencephalic nucleus of the trigeminal nerve.
Back side, you know.
Okay?
Shut up.
Huh?
I redraw it when I
Yes. On the lateral side of the periaqueductal gray, we have a nucleus. That is one of the nuclei of the trigeminal nerve. It is the mesencephalic nucleus of the trigeminal nerve. So that's one thing I've left out. Another thing I've left out is a nucleus just ventral to the aqueduct of Sylvius. Is the medial longitudinal fasciculus. Medial longitudinal fasciculus. Okay? Medial longitudinal fasciculus. Now that medial longitudinal fasciculus has an ascending limb and a descending limb. As you know, the ascending limb goes to cranial nerve 3, 4, and 6 for eye movement. And the descending limb goes to the cervical part of spinal cord for head movement. So the medial longitudinal fasciculus is important in coordinating eye movement and head movement.
And descending goes where is that?
Cervical part of spinal. I shouldn't have said that. It's spinal cord.
For head movement. Is that for head movement?
Yeah. Guys, I've given you every single thing you need. I've not withheld any information from you. Look here, guys. With respect to midbrain, everything that I know about the midbrain, you now know. I've given you everything.
Sir, so what happened to the level of the inferior? What's that?
That is another 2 hours.
Oh.
Right? So that's a different diagram.
Sure. You said to remind you about something. The lateral medullary syndrome.
Yes, guys. So look here now. Huh? Yeah. No, but not on this. On the level of the inferior colliculus. That's right. So when we do this, the midbrain at the level of the inferior colliculus, I'll show you the superior colliculus. Yes. So somebody asked me from the group yesterday now. WhatsApp me asked me about this. He said he was reading up this lateral medullary syndrome and he never understood something, right? So of course, the first thing to tell you is that he said one of the clinical features, the presenting symptoms of somebody with lateral medullary syndrome is that you have contralateral loss of pain and temperature from the body, which is true, but ipsilateral loss of pain and temperature from the face. And he said he never understood that part. Do you understand it?
Something about the cranial nerve.
So what do you think? First of all, which nerve is responsible for sensation to the face? Is it the facial nerve? It's the trigeminal nerve. Good. Good. And by the way, and which nucleus of the trigeminal nerve is responsible for pain and temperature? No, the principal nucleus is not responsible for that. Principal nucleus is responsible for vibration, sense, 2-point touch, and so on. So by the way, hold on. The trigeminal nerve, just to lay a foundation of 4 nuclei. It has a motor nucleus for the muscles of mastication. It has a principal nucleus for proprioception, not proprioception, for 2-point touch, vibration, and so on, pressure. It has a mesencephalic nucleus for proprioception. And then it has a pain nucleus, which is the spinal nucleus. That spinal nucleus extends from the medulla into the upper cervical part of the spinal cord. So if you have a lesion, and by the way, there are two such nuclei, one on the right and one on the left. And these nuclei are in the lateral part of the tegmentum of the midbrain, of the brainstem, of the medulla, lateral part. So if you have a lateral medullary syndrome, which can occur as a result of an ischemia, an ischemic event, a blood vessel burst, and no blood goes there, then that nucleus is going to die, right? And that nucleus is responsible for its own side. So if you have a lateral medullary syndrome, you're going to lose pain and temperature to that side, okay? But remember that pain and temperature from, say, the left side of our body. If I take a pin and stick in your left hand, it's going to enter the left part of the spinal cord and immediately cross over to the right side and ascend. So it will ascend up to the right side of the medulla, right side of pons, right side of midbrain before going to the thalamus. So if you have a right medullary syndrome, you're going to lose pain and temperature on the left side. You get that? Yeah, because this pain and temperature from the left side has to go cross and go up to the brain for you to feel it here. And if when it cross here, it can't go up, then you're not going to feel it here. Pain and temperature for this side, when I stick it across the midline, come on the left side of the spinal cord and go up. Right? You get that? So if anything happens on this side, you're not going to feel the pain and temperature on this side. So a lateral medullary syndrome will result in ipsilateral loss of pain and temperature on the face and contralateral loss of pain and temperature to the body.
What's against the back? On the back with the pain, it just goes straight up, right?
If what?
If you stick the person on like the back one.
No, if you stick the person, no, it's the same thing. It's the same thing. Any one side, we have to cross. So remember now, what determines which part of the spinal cord the crossing occurs, you think? What determines that? So if I stick you in the index finger, which part, level of the spinal cord do you think is going to go? The dermatome. What's the dermatome? C7, C7. So these two are C7, C7. Yeah, so these two are C7. I know that by heart because I got an essay on this. Right, so it's the dermatome that determines. What it means, therefore, is that eventually when this reaches spinal cord, it's going to cross at the level of C7. And when it crosses over, then it immediately shoots up. Right, and when it comes out of medulla, it's going to go into the pons, and all the pain will maintain its position in the lateral aspect of the tegmentum. Come out of the pons, go into the lateral part of the what? Tegmentum of the midbrain. But when it comes out of the midbrain, where do you think it is going to go? What's above the midbrain? Yeah, what's above the midbrain is the thalamus, or you can say the diencephalon. But it has to go into a part of the thalamus that only deals with pain and temperature from the body, and that's the VPL of the thalamus. When it comes out of VPL, it wants to go to the post-central, but how does it get there? Internal capsule, exactly. So that's how you have to think of it. All right? Anyway, guys, pay me and leave. I think guys, give me a round of applause. I think I've done an excellent job. Thank you.